Nursing Assessment, Respiratory System, Chapter 26. This is a review from class. The major passages and structures of the upper respiratory tract include the nostrils, nasal cavity, mouth, pharynx, and larynx. The respiratory system is lined with mucous membranes that secrete mucus, and the mucus traps smaller particles like pollen or smoke. Hair-like structures called the cilia line the mucous membranes and move the particles trapped in the mucus out of the nose. Inhaled air is moistened, warmed, and cleansed by the tissue that lines the nasal cavity. Olfactory nerve endings located in the roof of the nose are responsible for the sense of smell. Air moves through the oropharynx to the laryngopharynx, and then it travels through the epiglottis to the larynx before moving into the trachea. The epiglottis is a small flap located behind the tongue that closes over the larynx during swallowing. This prevents solids and liquids from entering the lungs. The vocal cords are located in the larynx, and the vibration sounds are made during respirations leading to the vocalization. Air passes through the glottis, the opening between the vocal cords, and into the trachea. The trachea bifurcates into the right and left mainstem bronchi at a point called the carina. The carina is located at the level of the manubriosternal junction, also called the angle of Lewis. The carina is highly sensitive, and touching it during suctioning causes vigorous coughing. The lower passages and structures of the lower respiratory tract include the trachea, and within the lungs, the bronchi, bronchioles, and alveoli. Deep in the lungs, each bronchus divides into secondary and tertiary bronchi, which continue to branch to smaller airways called the bronchioles. The bronchioles end in air sacs called the alveoli, and the alveoli are bunched together into clusters to form the alveolar sacs. Gas exchange occurs on the surface of each alveolus by a network of capillaries carrying blood that has come through the veins from other parts of the body. With the exception of the right and left mainstem bronchi, all lower airway structures are located inside the lungs. Once air passes the carina, it is in the lower respiratory tract. The right mainstem bronchus is shorter, wider, and straighter than the left mainstem bronchus. For this reason, aspiration is more likely to occur in the right lung than in the left lung. The right lung is divided into 3 lobes, upper, middle, and lower, and the left lung into 2 lobes, upper and lower. The frontal sinuses are air-filled cavities which lie between the lamina of the frontal bone. If there's any obstruction or blockages of the ethmoid sinuses, this usually causes inflammation of the frontal sinuses, which results in impaired mucus drainage. Accumulation of mucus secretions inside the moist, warm, and dark sinuses promotes growth of infectious agents. Like the inside of the nose, the sinuses are lined with a moist, thin layer of tissue called a mucous membrane. The mainstem bronchi divide several times to form the lobar, segmental, and subsegmental bronchi. Further divisions form the bronchioles. The most distant bronchioles are called the respiratory bronchioles. Beyond these lies the alveolar ducts and alveolar sacs. The bronchioles are encircled by smooth muscle that constrict and dilate in response to stimulus. The terms bronchoconstriction and bronchodilation are referred to the decrease or increase in the diameter of the airways caused by contraction or relaxation of these muscles. Oxygen and carbon dioxide exchange takes place in the alveoli. The trachea and the bronchi act as a pathway to conduct gases to the alveoli. The trachea plus the bronchi are called anatomic dead space. The air filling this space with every breath is not available for gas exchange. In adults, a normal tidal volume or volume of air exchange with each breath is about half a liter, 500 mLs, and that's about average for about a 150-pound male. Of each 500 mLs inhaled, about 150 is dead space. After moving through the dead space, air reaches the respiratory bronchioles and alveoli. The alveoli are interconnected by pores of Kohn, which allow movement of air to go from alveolus to alveolus. Deep breathing promotes air movement through these pores and assists in moving mucus out of the respiratory bronchioles. Bacteria can also move through these pores, leading to the spread of infection to previous non-infected areas. There are over 300 million alveoli in the adult lung. Alveoli have a total volume of about 2,500 mLs and a surface area for gas exchange that's about the size of a tennis court. Gases are exchanged at the alveolar capillary membrane, where the alveoli come in contact with pulmonary capillaries. In conditions such as pulmonary edema, excess fluid fills the interstitial space in alveoli, which reduces the gas exchange. Because alveoli are unstable, they have a natural tendency to collapse. And surfactant is a lipoprotein that lowers the surface tension in the alveoli, and it reduces the amount of pressure needed to inflate and decrease the tendency of the alveoli to collapse. Normally, a person takes a slightly larger breath called a sigh, about every 5 to 6 breaths. This sigh stretches the alveoli and promotes surfactant secretion. When there's not enough surfactant present, the alveoli will collapse. The term atelectasis refers to collapsed airless alveoli. A postoperative patient would be at risk for atelectasis because the effects of the anesthesia and the restricted breathing with pain. So in acute respiratory distress syndrome, there's a lack of surfactant, which contributes to widespread atelectasis. The lungs have 2 different types of circulation, pulmonary and bronchial. The pulmonary circulation provides the lungs with blood that participates in gas exchange. The pulmonary artery receives deoxygenated blood from the right ventricle of the heart and delivers it to the pulmonary capillaries that are directly connected with the alveoli. Oxygen-carbon dioxide exchange occurs at this point. The pulmonary veins return oxygenated blood to the left atrium, which then deliver it to the left ventricle for systemic circulation. The bronchial circulation starts with the bronchial arteries, which arise from the thoracic aorta. The bronchial circulation provides oxygen to the bronchi and other pulmonary tissues. Deoxygenated blood returns from the bronchial circulation and empties into the superior vena cava. The structures of the chest wall, the ribs, the pleura, the muscles of respiration, are also important. The chest cavity is lined with the membrane called the parietal pleura, and the lungs are lined with a membrane called the visceral pleura. The parietal and visceral pleura join to form a closed double-wall sac. The space between the pleural layers is called the intrapleural space. Normally, this space contains 20 to 25 mL of fluid. Now, this fluid has 2 purposes. 1, it provides lubrication, which allows the pleural layers to slide over each other during breathing. And 2, it increases cohesion between the pleural layers, which means it facilitates expansion of the pleura and the lung during inspiration. Contraction of the diaphragm and the major muscles of respiration result in decreased interthoracic pressure, which allows air to enter the lungs. Ventilation involves inspiration or inhalation, movement of air into the lungs, or expiration or exhalation, movement of air out of the lungs. Contraction of the diaphragm and intercostal and scalene muscles increases chest dimensions, which then decreases interthoracic pressure. Gas flows from an area of higher pressure, such as atmospheric, to one of lower pressure, like interthoracic. In contrast to inspiration, expiration is passive. Elastic recoil is a tendency for the lungs to relax after being stretched or expanded. The elastic recoil of the chest wall and lungs allows the chest to passively decrease in volume. Interthoracic pressure rises, which causes air to move out of the lungs. Oxygen and carbon dioxide are going to move back and forth across the alveolar capillary membrane by diffusion. The overall direction of movement is from the area of higher concentration to an area of lower concentration. Diffusion continues until equilibrium is reached, and perfusion is how the blood flows along the alveoli. Compliance, also known as distensibility, is a measure of the ease of expansion of the lungs. This is a product of the elasticity of the lungs and the elastic recoil of the chest wall. When compliance is decreased, the lungs are more difficult to inflate. Compliance is increased when there is destruction of alveolar walls and loss of tissue elasticity, as in COPD. ABGs are measured to determine oxygenation status and acid-base balance. ABG analysis includes measurement of the PaO2, PaCO2, acidity, pH, and bicarbonate, the HCO3, that's in the arterial blood. The SaO2 is either calculated or measured during this analysis. Blood for blood gas analysis can be obtained by arterial puncture or from an arterial catheter, usually in the radial or femoral artery. Both locations allow only for intermittent analysis. Continuous intra-arterial blood gas monitoring is also possible via a fiber optic sensor or an oxygen electrode inserted into the arterial catheter. Arterial oxygen saturation can be monitored non-invasively and continuously using a pulse oximetry probe on a finger, toe, ear, or bridge of the nose. The abbreviation SpO2 is used to indicate the oxygen saturation of hemoglobin when pulse oximetry is used. The SpO2 and the heart rate are displayed on a monitor as digital readings. A chemoreceptor is a receptor that responds to a change in the chemical composition, the PaCO2 and pH of the fluid around it. Central chemoreceptors are located in the medulla and respond to changes in the hydrogen ion concentration. Peripheral chemoreceptors are located in the carotid bodies at the bifurcation of the common carotid arteries and the aortic bodies above and below the aortic arch. The peripheral chemoreceptors respond to decreases in the PaO2 and the pH and to increases in the PaCO2. And these changes also cause stimulation of the respiratory center. Mechanical receptors are located in the lungs, in the upper airways, chest wall, and diaphragm. They are stimulated by a variety of physiological factors such as irritants, muscle stretching, and alveolar wall distortion. Signals from the stretch receptors aid in the control of respiration. As the lungs inflate, pulmonary stretch receptors activate the inspiratory center to inhibit further lung expansion. This term is called the Herring-Brewer reflex, and it prevents overdistension of the lungs. Juxtacapillary receptors are believed to cause the rapid respiration tachypnea seen in pulmonary edema. These receptors are stimulated by fluid entering the pulmonary interstitial space. The cough is a protective reflex action that clears the airway by a high-pressure, high-velocity flow of air. It is a backup for mucociliary clearance, especially when this clearance mechanism is overwhelmed or ineffective. Coughing is only effective in removing secretions above the subsegmental level, the large or main airways. Secretions below this level must be moved upward by the mucociliary mechanism before they can be removed by coughing. Reflex bronchostriction is another defense mechanism. In response to the inhalation of large amounts of irritating substances like dust or aerosols, the bronchi constrict in an effort to prevent entry of the irritants. A person with hyperreactive airways, such as a person with asthma, may experience bronchoconstriction after inhalation of triggers like cold air, perfume, or other strong odors. Because ciliated cells are not found below the level of the respiratory bronchioles, the primary defense mechanism at the alveolar level is alveolar macrophages. These macrophages rapidly phagocytize inhaled foreign particles like bacteria. The debris is moved to the level of the bronchioles for removal by the cilia or removed from the lungs by the lymphatic system. When performing a respiratory assessment, look, listen, feel. Chart the presence or absence of particular breath sounds. Think about how should a patient be positioned to increase lung expansion. The upright position with the arms supported increases lung expansion and expands the intercostal spaces so that access to the pleural space is easier. The stethoscope should be placed over lung tissue, not over bony structures, and breath sounds should be compared from side to side. Suctioning wall pressure setting for adults requires suction of 80 to 120 millimeters of mercury. The term abnormal breath sounds describes bronchial or bronchiovesicular sounds heard in the peripheral lung fields. Adventitious sounds are extra breath sounds that are abnormal. Fine crackles are a series of short-duration, high-pitched sounds heard just before the end of inspiration. Coarse crackles are long-duration, low-pitched sounds caused by air passing through airway intermittently occluded by mucus, unstable bronchial wall, or fold of mucosa. Bronchial or loud and tubular breath sounds are abnormal in peripheral areas where only vesicular, soft and rustling sounds should be heard. When bronchial sounds are heard in areas distant from where they are normally occur, the patient may have consolidation, as it happens with pneumonia, or compression of the lung. These conditions cause the lung tissue to be dense. The dense tissue transmits sound from the lung bronchi much more efficiently than through air-filled alveoli of the normal lung. Bronchial sounds are present over the large airways in the anterior chest near the second and third intercostal spaces. These sounds are more tubular and hollow sounding than vesicular sounds, but not as harsh as tracheal breath sounds. Bronchial sounds are loud and high in pitch with the short pause between inspiration and expiration. Expiratory sounds last longer than inspiratory sounds. Tracheal breath sounds are heard over the trachea, and these sounds are harsh and sound like air is being blown through a pipe. Bronchovesicular sounds are heard in the posterior chest between the scapula and in the center part of the anterior chest. These sounds are softer than bronchial sounds but have a tubular quality. Bronchovesicular sounds are about equal during inspiration and expiration. They differ in pitch and intensity and are often more easily detected during expiration. Vesicular sounds are soft, blowing, or rustling sounds normally heard throughout most of the lung field. These sounds are normally heard throughout inspiration, continue without pause through expiration, and then fade away about 1/3 of the way through expiration. Heart disease can cause breathlessness if the heart is unable to pump enough blood to supply oxygen to the body. If the brain, muscles, or other body organs do not receive enough oxygen, that sense of breathlessness can occur. Sometimes emotional distress like anxiety can lead to difficulty breathing, like when you all take a nursing exam. The coloration of the skin is caused by the amount of pigment in the skin and the blood flowing through it. Blood that is saturated with oxygen is bright red. Blood that has lost oxygen is dark red. People whose blood is low in oxygen tend to have a bluish color to their skin. This cyanosis can be caused because of the lack of oxygen, like in suffocation or cyanotic heart disease, abnormal hemoglobin, toxins like cyanide. Most cyanosis occurs as a result of heart disease like congestive heart failure, lung disease, or cardiopulmonary arrest. Mild cyanosis could be a little bit harder to detect. Usually the oxygen saturation of the blood has to drop below 90% before cyanosis occurs. In dark-skinned people, cyanosis may be easier to see in the mucous membranes, like the lips, gums, around the eyes, and the nail beds, rather than in the skin. It may also appear on the feet, nose, and ears. So just like what happened during our skills lab, if you're thinking about giving oxygen, give it. Cyanosis, oxygenate immediately. Especially decreased level of consciousness. If you think they could be going to shock or they have hemorrhage, chest pain, chest trauma, respiratory distress, if you think about it, give it. Part of your secondary assessment is to look at how they're breathing. Kussmaul's breathing is the deep, labored breathing with increased frequency found among people with severe acidosis. It's a form of hyperventilation. The cause of Kussmaul's breathing is respiratory compensation for a metabolic acidosis, most commonly occurring in diabetic ketoacidosis. Blood gases on a patient with Kussmaul's will show a low pCO2 because of forced increased respirations, because they're blowing off the carbon dioxide. The patient feels an urge to breathe deeply, almost like they're saying they have air hunger, and it appears almost involuntarily. A metabolic acidosis soon produces that hyperventilation, but at first it will tend to be rapid and relatively shallow. Kussmaul breathing develops as the acidosis grows more severe. Cheyne-Stokes is an abnormal type of breathing seen especially in comatose patients, and this is characterized by alternating periods of shallow and deep breathing. So you think of that when a patient aspirates, how long before your hair crackles? Well, it's not going to be right after aspiration because the inflammatory process will take time to occur. So it's important that you would assess a patient's ability to swallow. Assessing the ability of a patient to drink a colored fluid like grape juice will provide evidence that the patient will not aspirate. Even if the patient is able to talk, aspiration can occur. Rhonchi are continuous rumbling, snoring, or rattling sounds from obstruction of large airways with secretions, most prominent on expiration. Wheezes are continuous high-pitched squeaking or musical sounds caused by rapid vibration of the bronchial walls, first evident on expiration, but possibly on inspiration as obstruction of the airway increases. Stridor is a continuous musical or crowing sound of constant pitch. This results of a partial obstruction of the larynx or trachea. A pleural friction rub is a creaking or grating sound from a roughened, inflamed pleural surfaces that are rubbing together. This is evident during inspiration, expiration, or both, and no change with coughing. It is usually uncomfortable, especially on deep inspiration. Sputum samples can be obtained by expiration, tracheal suction, or bronchoscopy. When the patient is unable to expectorate spontaneously, sputum may also be collected by inhalation of an irritating aerosol, usually a hypertonic saline. This is called sputum induction. The specimens may be examined for culture and sensitivity to identify an infecting organism, like Mycobacterium or Pneumocystis, or to confirm a diagnosis, like malignant cells. Regardless of whether the specimen tests are ordered, it's important to observe the sputum for color, blood, volume, and viscosity. Skin tests may be performed to test for allergic reactions or exposure to TB, bacilli, or fungi. Nursing responsibility are similar for all skin tests. First, to prevent a false negative reaction, be certain that the injection is intradermal and not subcutaneous. After the injection, circle the site and instruct the patient not to remove the marks. When charting administration of the antigen, draw a diagram of the forearm in hand and label the injection sites. The diagram is especially helpful when more than one test is administered. When reading test results, use good light. If an induration is present, use a marking pen to indicate the periphery on all four sides of an induration. As the pen touches the raised area, make a mark. Then determine the diameter of the induration in millimeters. A positive result on a TB skin test indicates that the patient has been exposed to the antigen. It does not indicate that TB is currently present. A negative result indicates that there has been no exposure, or there's a depression of cell-mediated immunity, such as occurs with HIV infection. Bronchoscopy is a procedure in which the bronchi are visualized through a fiber optic tube. A bronchoscopy may be used for diagnostic purposes to obtain biopsy specimens and assess changes resulting from treatment. Small amounts of sterile saline may be injected through the scope and withdrawn and examined for cells, and this is a technique termed bronchoalveolar lavage. Bronchoscopy is also used for treatment. For example, mucus plugs or foreign bodies can be removed. Laser therapy, electrocautery, cryotherapy, and stents may be placed through a bronchoscope to achieve patency of an airway that has been completely or partially obstructed by tumors. After the nasopharynx and oropharynx are anesthetized with a local anesthetic, the bronchoscope is coated with lidocaine and inserted usually through the nose and threaded down into the airways. Because a local anesthetic is used to suppress the gag cough reflexes during the bronchoscopy, the nurse should monitor for the return of these reflexes before allowing a patient to take any PO fluids or foods. Blood-tinged mucus is not uncommon after a bronchoscopy, so remember you're looking at expectation versus complication. A patient doesn't have to be on bed rest, and the head of the bed does not need to be in a high Fowler's position. A bronchoscopy is used to inspect for changes in the bronchial tree. It is not to assess for vascular changes. A lung biopsy may be done transbronchially, percutaneously or via transthoracic needle aspiration, or by video-assisted thoracic surgery or an open lung biopsy. The purpose of a lung biopsy is to obtain tissue, cells, or secretions for evaluation. The biopsy is used when pulmonary disease cannot be diagnosed by other procedures. The percutaneous needle aspiration involves inserting a needle through the chest wall, usually under CT guidance. Because of the risk of pneumothorax, a chest X-ray is ordered after the procedure. In a video-assisted thoracic surgery, a rigid scope with a lens is passed through a trocar placed in the pleura via one or two small incisions in the intercostal muscles. The physician views the lesions on a monitor, and the biopsy specimens can be taken. A chest tube is kept in place until the lung expands. Thoracentesis is the insertion of a large bore needle through the chest wall into the pleural space to obtain specimens for diagnostic evaluation, remove pleural fluid, or instill medication into the pleural space. The patient is positioned sitting upright with the elbows on an overbed table and feet supported. The skin is cleansed and a local anesthetic is instilled subcutaneously. A chest tube may be inserted to permit further drainage of the fluid. Pulmonary functions tests measure lung volumes and airflow. The patient should inhale deeply and exhale as long, hard, and fast as possible. The results of a pulmonary function test are used to diagnose pulmonary disease, monitor disease progression, evaluate disability, and evaluate response to bronchodilators. Exercise testing is used in diagnosis and determining exercise capacity. A complete test involves walking on a treadmill while expired oxygen and carbon dioxide, respiratory rate, heart rhythm are monitored. In a modified test, a desaturation test, only the SpO2 is monitored. The 6-minute walk test is used to measure functional capacity in response to treatment in patients with heart or lung disease. Chest X-ray is used to screen, diagnose, and evaluate changes in respiratory system and will not be diagnostic for a pulmonary embolus. A CT is performed for diagnosis of lesions that are difficult to assess, like the mediastinum, the hilum, the pleura, by conventional X-ray studies. Spiral CT scans are the most commonly used to diagnose a pulmonary emboli. An MRI is for diagnosis of lesions difficult to assess by CT scan, like the lung apex. Ventilation perfusion scan is used to assess the ventilation and perfusion of the lungs. This is also known as a VQ scan. IV radioisotope is given to assess perfusion. For the ventilation portion, the patient inhales a radioactive gas like xenon or krypton, which outlines the alveoli. Diminished or absent radioactivity suggests lack of perfusion or airflow. Ventilation without perfusion suggests a pulmonary embolus. A pulmonary angiogram is used to visualize pulmonary vasculature and locate obstruction or pathological conditions like a pulmonary embolus. Contrast medium is injected in a catheter threaded into the pulmonary artery or right side of the heart. A series of X-rays are taken after the contrast medium is injected into the pulmonary artery. A positive emission tomography or PET scan is used to distinguish benign and malignant pulmonary nodules and is most useful in determining the presence of malignancy. The oxyhemoglobin dissociation curve. This curve describes a relationship between available oxygen and the amount of oxygen carried by hemoglobin. The oxygen-hemoglobin affinity changes with variations in pH, CO2, temperature, and 2,3 dPg. A left shift will increase the oxygen's affinity for hemoglobin. In a left shift condition like alkalosis and hypothermia, oxygen will have a higher affinity for hemoglobin. The SaO2 will increase at a given PaO2, but more of it will stay on the hemoglobin and ride back through the lungs without being used. This can result in tissue hypoxia even when there is sufficient oxygen in the blood. A right shift decreases oxygen's affinity for hemoglobin. So in a right shift, acidosis and fever, the oxygen has a lower affinity for hemoglobin, which means the blood will release the oxygen more readily. This means more oxygen will be released to the cell, but it also means less oxygen will be carried from the lungs in the first place.